Right, we'll get started then. So I hope you can see the slides and hear me okay. If there's any problems, just pop in the chat because I can see the chat. Okay, so welcome everybody. Thank you for coming to another one of our Back to Basics bite-sized lunchtime sessions. Today we're going to talk about adult safeguarding, how to make a good and appropriate referral, and this is aimed at all levels. Even your level 1 staff can, attend this, or they can watch the recording afterwards. For any of you who don't know me, I'm Yasmin Hussain. I'm one of the named GPs for the Birmingham and Solihull ICB, as we're now known, safeguarding team. Confidentiality, this is being recorded and the link will be shared via the ICS briefing. So I do welcome you to discuss any cases you want to, but please just remember, don't use any patient identifiable information. Thank you. And the warning slide, just reminding you to look after yourselves and get support. Abuse is common. Abuse can be upsetting and triggering. So, and you're welcome to contact us as well if anything comes up for you that you want to discuss. We have a support and advice helpline. If you're not aware, please put this number in your mobile phones, and it's manned Monday to Friday 9 till 5. And at the end, I will ask you, I'll put this slide up again, if you could give feedback on the session, what you've learned, and just generally for the bite-sized sessions, if there's any topics you want to see covered, please do put that in the chat. There's no certificates for this. What we recommend is, as per the intercollegiate documents, record this safeguarding training in completing a reflection log and include it in your appraisals. Okay, so in order to make a good and appropriate referral, you need to understand 5 key components of the process of adult safeguarding. So what are these 5 things? Number 1 is know who to refer, risk enablement, be able to assess mental capacity, know what the referral procedure is, and understand and make use of early help. So we're going to go through these 5 things. So number 1, who do we refer? So we follow in England and Wales the Care Act 2014, and that tells us that adult safeguarding does not mean protecting. Oh, can everybody go on mute, please? Oh, Mehreen, welcome. You're not on mute.
I beg your pardon. I'm so sorry.
Okay, thank you. So the Care Act 2014, it says specifically adult safeguarding does not mean protecting every adult from every kind of harm or risk to their personal safety. The Care Act tells us the statutory safeguarding responsibilities. So in other words, what are the council responsible for in terms of their social services setup? So these are the specific people that they will look after, safeguard. The adult has to have care and support needs, whether or not these are being met or not. So they don't necessarily have to have a carer, but they have to have needs that where they need a carer, so to speak. They need to be experiencing or at risk of abuse or neglect, and as a result of their care and support needs, they are unable to protect themselves from either the risk of or the experience of abuse or neglect. So, for example, this lady in the picture, this lady in the wheelchair, her carer is obviously, shouting abuse at her and is fighting with her. She is trapped in a wheelchair. She can't get up and get away from the abuse or fight back. So she would be covered by adult safeguarding according to the Care Act. I, on the other hand, would not be covered. I don't have any care and support needs. The idea of the Care Act is that if I was being exposed to abuse, I can get up and walk away, or I can pick up the phone and call the police. As we know, in reality, in situations of domestic abuse, it's not always that easy for the victim to come out of that relationship. But for the purposes of the Care Act, for the purposes of when social services will intervene, they follow these criteria. Okay, I hope that's clear. So who are these adults with care and support needs? They're anybody aged 18 or over who needs extra help to manage their lives. So not all elderly, but elderly specifically with frailty, disability or cognitive impairment, things like dementia, learning disability, any mental health needs, including personality disorders, any long-term illness or condition, which means they need help to live their lives. So, a chronic COPD who's on oxygen, somebody with crippling rheumatoid arthritis, all these kind of conditions count. So I've just copied the previous slide onto this because in general practice, so that's for social workers, in general practice, obviously we need to safeguard these patients as well, but we have another group of patients on our list who we need to safeguard as well. And these are called vulnerable adults or at-risk adults. And these are adults who are exposed to other social factors which aren't included under the care and support needs. So they don't have care and support needs, but they have vulnerabilities. So living alone, low self-esteem, being socially excluded or isolated, misusing drugs and or alcohol, having mental illness, so severe anxiety, depression, the bipolar schizophrenia, and then dual diagnosis. 50% of adults in the UK have what's known as dual diagnosis, and this is the combination of mental illness with drug and or alcohol misuse. And the reason I highlight it to you is these are the adults that turn up time and time again. Unfortunately, they die early, and then they are the subject of safeguarding adult reviews. So it's really important for us in general practice to be aware of these people that are on our list and put alerts on and give them extra special attention. Other adults who are vulnerable: offending history, they've been to prison, homelessness, domestic abuse relationships, ethnicity or immigration status, because maybe they may be the subject of racist attacks, and gender or sexuality. So, for example, they may be the subject of, say, a homophobic attack. So this is a process of safeguarding. If we draw a pyramid, social services only deal with the tip of the iceberg, those with care and support needs. So number 2, risk enablement. Can you just quickly put in the chat who has heard of risk enablement? Because it's part and parcel of adult safeguarding, but so many people have not heard of it. I did forget to say, so this is supposed to be interactive. So if you can pop in the chat, we've got some case studies at the end as well that I'd like you to contribute to. So this is what risk enablement is about. We think of it as a set of scales. On the one side, on the left-hand side, there's risk. We have a duty of care to our patients. If we identify any risk, of course, we're going to take steps to ensure their safety. And for children, that's absolute. The difference is with adults, on the other side of the scales, there is enablement. We also at the same time have a duty to support our adult patients, to enable them to have independence, choice and control over their own lives, just as we would want, wouldn't we, if we were in that situation. So it's a case of we don't go to our adult patients and say, this is what we're doing for you. We need to go and say, what would you like us to do for you? So that again, it's in the Care Act. It's about making safeguarding personal, and the motto is no decision about me without me. But of course, that all hinges on mental capacity. So therefore, the third thing that we need to do, obviously, is to be able to assess mental capacity. So I'm just going to quickly revise that with you. So the thing is that we don't do it on a regular basis, so we do forget. So according to the Mental Capacity Act, we use it for one decision at one particular moment in time. And there are 5 statutory principles. And I was wondering, shall I be mean to you and see if you can remember any of the statutory principles? If you can, pop them into the chat just now. I'll give you 10, 15 seconds. Can anybody remember any of the 5 statutory principles? If you want to, or just have a think yourself and see if you can remember them. Okay, so I'll put you out of your misery. So the first one is that you always presume capacity unless demonstrated otherwise. In other words, the onus is on us to prove that the patient doesn't have capacity. The patient doesn't have to prove whether they've got capacity or not. We offer help and support to individuals to make their own decisions. Individuals do have the right to make eccentric or unwise decisions. Even from where we're standing, from our point of view, we think, no, this isn't wise, this is risky, it's dangerous. But if a person has mental capacity, they are allowed to make those sort of decisions for themselves. Always act in the individual's best interests when taking a decision, and always take the least restrictive option wherever possible. So if a patient doesn't have mental capacity and they've always wanted to live at home, but now they can't manage so well, rather than putting them straight into a nursing home, we could put in a care package first. So, carers going in 4 times a day to help them. So that would be the least restrictive option. The key thing is, before deciding that someone lacks capacity to make a particular decision, it is important that we take all practical and appropriate steps to enable them to make that decision themselves. So we provide them videos to watch, leaflets in Braille, whatever it takes for them to understand. So the actual assessment of mental capacity is a 2-stage test. Number 1 is, the first question we ask is the patient unable to make the decision in question at the time it needs to be made? And a person is unable to make a decision if they can't understand the information about the decision, if they can't retain the information in their minds to make the decision, if they cannot use or weigh that information as part of the decision-making process, or if they can't communicate that decision. And it doesn't have to be verbal. They can, use sign language, Makaton. They can even blink their eyes for a yes or no, or even squeeze a person's hand, when verbal communication is not possible. But if they can't do one or more of those things, they're unable to make the decision. So then we move on to number 2. If so, if they can't make the decision, is there an impairment of or a disturbance in the functioning of the person's mind or brain causing their inability to make the decision? And it doesn't matter whether that impairment or disturbance is temporary or permanent. And so the kind of things we're thinking about, possibly dementia, severe learning disability, even possibly brain damage following a car accident, or in cases of severe infection, you can get sepsis. Now, for those of you who are familiar with the mental capacity and you use it quite a lot, you'll be thinking to yourself, Yasmin doesn't know what she's talking about. She's got them the wrong way round. So I have been reliably informed by people who know about these things that apparently the Mental Capacity Act has had it wrong all this time. And this is the correct order to do it in. We decide first whether the patient can't make the decision, then we look for the impairment of the brain. And apparently the Mental Capacity Act is being reviewed as we speak. And in the new version, you'll see that this is how they're going to put it. And so if a person doesn't have an impairment or disturbance of the mind or brain, they don't lack capacity under the Act. So it might be just that we need to assess the capacity for the decision again at a later date. That might be an example. So here's a case study. My patient, Mrs. Jones, is 83 years old. She lives alone and she's independent. And remember, I can't say she's got mental capacity because you can only say she's got mental capacity to be able to decide what treatment she's on. She's got mental capacity to decide where she lives. She's got mental capacity to manage her money. We have to speak like that. So all I can say about Mrs. Jones is I don't know of any impairment of the brain she's got. Okay. So then her neighbour phones me up and says, I'm worried about Mrs. Jones. She's coughing a lot. So I go out, she's got a chest infection, high temperature, and it looks like she's in sepsis. So she has lost her capacity now. If I did an assessment, she doesn't know who she is, where she is, etc. So I decide she needs to go to hospital, but she can't give me consent for that. So I make a best interest decision. I call the ambulance and get her sent into hospital. When she gets into hospital, the doctor wants to start IV antibiotics. Again, she can't give consent for that. So the hospital doctor will start those antibiotics under a best interest decision. At the same time, just before she took ill, the social worker was going to be meeting with her to have a discussion about her moving into sheltered accommodation. That kind of decision obviously isn't essential right now, so the social worker would defer that and wait until she's come back out of hospital and hopefully she's regained her capacity. So I hope that makes sense. If a patient doesn't have mental capacity, there is no automatic next of kin for making decisions. We often have adult children of our elderly patients. They come forward and say, doctor, I can make that decision for my mum. I'm the next of kin. So we have to explain, unfortunately, next of kin is just a legal term purely for inheritance purposes. It doesn't mean that person can make health decisions for them. What we need to ask is, while your parent or the adult, when they did have capacity, did they leave any advance directives? Did they make any? So like a living will, an ADRT, an advanced decision to refuse treatment, or a lasting power of attorney. And just to remind you, there's two, one for finances, one for health and welfare. So obviously we're concerned with the health and welfare one. They are legal documents. To be legal documents, they have to be registered with the Office of the Public Guardian. And the cost at the moment is £82 each. And the reason I know that is because I've just done lasting powers of attorney for myself, and I would strongly encourage all of you as well to have a think. If heaven forbid something happened to you and you are no longer able to make decisions for yourself, who in your life do you trust to come forward and make those decisions for you and go ahead and set up your lasting powers of attorney? For a lot of our patients, £82 each is too much. So actually any piece of paper, even a scrap of paper that they've written their name and address and date of birth, they've written down what they want and what they don't want, and they've signed it and they've had it witnessed, that counts. They can give it to us and we can scan it into their medical records. So even before capacity is lost, we should start asking our patients, have you made a lasting power of attorney for health and welfare or a living will? Ask for a copy. We can scan it in, we can code it. We can also put the code has appointed person with a lasting power of attorney, and you can put the person's name and their relationship, and obviously put some sort of alert, system one, the homepage, EMIS, the manage box, that the patient has a lasting power of attorney for health. The POA is whoever, and the date that it's been scanned so that you can refer back to it. If there's a complex or difficult decision that needs to be made and there's no lasting power of attorney, no advanced directive to refuse treatment, no friends or family that we can talk to, we can arrange an IMCA, an independent mental capacity advocate. And the IMCA service under the Care Act is supposed to be provided free by the CCG, who are now an ICS. So it's free for the patient, it's not means tested. And we can make referrals to the IMCA and share all the patient's details on a best interest basis. So we're not breaching their confidentiality if we make a referral. Or you can refer to adult social services, who can then go to the Court of Protection. They can appoint a power of attorney to make decisions for that adult, or they can go to the Office of Care and Protection, who then can make directly can make decisions for the patient. So there's lots of options. And if you're not sure, give us a call. And then documentation is key. When you've made a decision, how did you ascertain the patient's previous wishes and feelings? Who did you talk to and what were their views? And why do you think the decision you have made is in the patient's best interest? And I would always recommend just double check, take advice from your medical defence union. And the reason is why, because this could happen, and indeed it has happened. Once the elderly person passes away, the adult children will come to us, and let's say in the person's will, they didn't get what they wanted. So they're going to come to us, the GP, and say, at the time my mum made the will, you said she had mental capacity, but I don't believe she did. And that's why, and that may be, 2, 3, 4, 5 years later. So we need to make sure our documentation is watertight. Okay, moving on. So number 4, you've decided that you do need to make a referral, and then what is the referral procedure? Because hopefully most of you are not making adult safeguarding referrals on a regular basis. When you do come around to make one, you're going to be thinking, well, how do I do it? I've forgotten. Where's the referral form, etc., etc. So let's go through that quickly. So I'm going to cover Birmingham first, and then I'll do Solihull. So in Birmingham, in every town and city, again, according to the Care Act, needs to have a safeguarding adults board, and the Care Act defines who the statutory partners are. So for Birmingham, you've got to have the City Council, because they run the adult social services. You've got to have the CCG, or the ICS as we're now called. The police are a member of the board. The fire service are a member of the board. Because we deal with mental health and mental capacity, you've got to have mental health services. Healthwatch Birmingham is an independent organisation where citizens of Birmingham can go if they need to report any adverse experience that they've had with the NHS or with social services, and Healthwatch will take it up for them. And then obviously, as we've said, adults who need safeguarding are often need carers, so we need organisation to support the carers. So we've got Forward Carers in Birmingham. So this is a screenshot of the adult safeguarding board, and here's the tab Report a Concern. So when you click on that, it takes you straight to the Birmingham City Council website, because remember, they're the ones who pay the social workers. And here is the screen. It says report possible abuse or neglect of an adult with care and support needs. Now before, there was 2 sites, one for members of the public to make a referral and one for professionals. Now they've just merged it. Whether you're a member of the public, you want to report your next door neighbour, you've seen something in the supermarket, you've seen something in the park, or whether you're a health professional, you're working in primary care, we all use the same website. So the idea is even your level 1 staff, anybody in your practice can go ahead, if they've spotted something, they can make the referral. You don't need to do that. It doesn't need to go to a level 3 or the safeguarding lead. They can make the referral themselves. So you click on there, begin this form. So obviously you're going to start with giving the details of the person that you're concerned about, and then you'll give your details. And then it says details of the concern. Please give as much information to the who, what, where, when, why, and how. And then give information about the perpetrator. And remember, it could be organisational abuse. It could be a care home that you're accusing of abusing the patient. So you put all those details there. And then, does the person know that you are contacting us? And ideally, obviously, the answer should be yes. You should have had that conversation with them and explain that you're making a referral for them. If you click no, then they want to know why not. Because remember, making safeguarding personal, no decision about me without me. So the answer there would be the patient doesn't have capacity. They don't understand that they're at danger. They can't give me consent. So that would be the most obvious reason. Or the other reason might be, I couldn't discuss it with the patient because I believe that would increase their risk of abuse, and that's why I couldn't tell them. So that would be another reason. Those would be the 2 main reasons. And then it says, do you have any immediate concerns for the person's safety? And what is the best way for us to contact the person? Is there anyone else we can speak to on their behalf? Especially, for example, patients with dementia, you might want to put a family member or somebody like that. And then we have, are there any children or young people who may be at risk? And if you click yes, then it says, have you contacted Birmingham Children's Trust? So I do like Birmingham Adult Social Services for creating this website, because that's a really good reminder. Because remember that wider thinking. When we've got an adult in front of us, we think about their care and support needs, we think about their vulnerabilities, but then we have to ask, do you have any children? Because if you need help looking after yourself, who's helping you look after your children? Or do you have responsibility for any children, stepchildren, grandchildren, or do you have access to any children? Because if you've got an adult who's got severe mental illness or who's misusing drugs and alcohol, we have to think, what happens if you're in a room with your niece and nephew on your own? You know, what could potentially happen? So we've got to think adult, think child, and then think family. Think about the other family members, who is supportive, who is not so supportive, other family factors like poverty, overcrowding, the area where they live, maybe there's a lot of crime, racism, homophobia, etc. And then think carer. Some adults, even if they've got care and support needs of their own, can sometimes still be carers for their elderly parents who've got dementia, or they may have an adult child who's got learning disability. Or vulnerable adults that they might be carers. So we need to be asking those questions as well. Do you have any caring responsibilities for anybody within the family or outside of the family? So just to reinforce the point, so with children safeguarding, when a child is identified to be in a household where there are safeguarding concerns about an adult, then the child should be referred to Children's Social Services. That's fine, isn't it? We know that. But the key thing is by the person identifying the adult abuse. So that would be you if you're making that referral. We could be thinking, well, we're referring to social services anyway, adult social services. They're going to come in, they're going to do the assessment, and they'll pick up the children and they'll make the referral. And in fact, that's better, isn't it? Because one adult social services to another children's social services, they've got direct communication, it's a better referral, etc., etc. Children's social services will take them more seriously. We can tell ourselves all of that. And that is all true. However, I promise you would be severely criticised if you left it to the adult social worker. You need to make that referral as well. So Children's Social Services may get 2 referrals, one from you, one from Adult Social Services, that's fine, but you need to be making that referral as well. Okay. So then moving on to the final question then is, has the incident been reported to the police? So these are all the questions, and I'll send you this. I forgot to say, this will be shared, as I said, in the ICS briefings, but if you want me to email you directly, I'm more than happy to do that. Just put your email in the chat and I'll send you the recording and the presentation and all these, there's a couple of accompanying documents. So this on a page is all the questions that you need to answer. And then it does say, before you submit this form, please check that the person you're referring has care and support needs and is subject to or at risk of abuse or neglect, and as a result of their care and support needs, they are unable to protect themselves from this risk. Remember that slide I said from the Care Act? So Birmingham, because they've got finite funds, they have to really keep their rules and regulations, and they stick to the Care Act, exactly what it says. And where the above does not apply, so they don't have care and support needs, but you still feel the patient requires support, then please consider making a referral to social care, which of course is a different pathway. Okay, and then you submit the form. So if they don't have care and support needs, don't start the form because you'll just have wasted your time. And again, I've put it on a page, as I said, we're not doing it every day. So this is something you can stick up in every clinical room and in every consulting room. And you can have it, up in reception. Imagine the scenario where there's just a locum and the receptionist, and the locum comes out and says, I need to make a referral. The receptionist can say, oh, well, here's what you need to do, doctor. Just follow this, these guidelines. And again, reminding you, your referral will be rejected if the adult does not have care and support needs, and your referral will be rejected if the person has mental capacity and they haven't given you consent. Okay. Moving on to Solihull. So same again, Solihull has a Safeguarding Adults Board. Statutory partners will be the same, the council, the ICS, the police, the fire service. They have University Hospitals Foundation Trust. They have the same Mental Health Trust. They have Age UK Solihull for 55 and over. They have Solihull Carers Trust, and they also have Solihull Action Through Advocacy, which is a special organisation to support adults with autism and learning disability. That's a screenshot of their website, and there is the big tab, report a concern about an adult. Now with Solihull, because they have a smaller number to deal with, you've got 3 options. You can actually just phone them and tell them the problem. If it's not urgent, you can email them, you can send them a referral letter, or you can complete the online form. So here's the online form, report adult abuse. Again, you give the details of the patient. And the key question is the person you're concerned about safe at the moment? Because they need to kind of know, do we need to act today? Can we leave it a few days or a week? And then the GP details and next of kin, and again, it would be your details for fulfilling the form. So you can see quite straightforward, quite simple. So again, on a page, you've got the 3 options. You can phone them, email them, or fill the online form. Put the code referred to Social Services for Adult Protection, because you may be asked to, audit, how many referrals have you made in a year, and then you've got your support and advice. And that's the questions. So what I've done is I've done them side by side. You can see colour coded, so it's pretty much the same, except for Birmingham add this extra red bit and the black bit. And if you do make a referral, remember the referrer has an ongoing responsibility for any referrals made. It's a bit like a 2-week wait. You don't just refer them, you know, for query cancer. You would follow them up and make sure that they've been seen, etc. So you do the same for social services and provide an email address so that they can respond to you. And if they do take it up, they open what's called a Section 42 inquiry. They will establish the facts. They will speak to the adult if the adult is capable of speaking to them to ascertain their views and wishes. If not, they'll talk to their nearest and dearest, and they'll come to us as well for information. They'll assess the need for protection. They'll take the actions needed to protect the patient and any actions they need to do regarding the perpetrator as well. If they haven't responded the way you expected them to, then what you need to do is escalate. You would speak to the social worker first and try to understand, you know, why they've not dealt with it, dealt with the things that you were worried about. Speak to your safeguarding lead for the practice, and if you are the safeguarding lead for the practice, you can contact us, obviously the safeguarding team, and we will help support you for escalation. The key message is, though, never do nothing. If your alarm bells are ringing, you must take action. And then finally, understand and make use of early help. So as I said, social services only deal with the tip of the iceberg. So the majority of safeguarding work actually takes place in the community with ourselves, with other NHS services and lots of non-NHS services. And we call it early help. So partnership working to safeguard adults. So our patients may be under the care of the elderly team. They may be under the learning disabilities team. The district nurses may be going in, for example, to address a leg ulcer. We've talked about vulnerable adults. We may have referred them to, for example, in Birmingham to Change, Grow, Live. They may have a key worker. The police may be involved. So community psychiatric nurses, voluntary organisations, charities like Birmingham and Solihull Women's Aid. The fire service. If you came to my talk a couple of weeks ago, I mentioned that for people with hoarding, the fire service can get involved. Carers, that would be paid and unpaid carers. Friends and family. Housing officers have a safeguarding duty for the people that they house. People in the community, like the local shopkeeper, the park warden, if our adult patient goes to the library, even, you know, the local librarian, these kind of people in the community who are seeing our patients, any other council services, any other support worker from any organisation, and then finally adult social services. And the reason I include this slide is I want you to get a sense of all the blue bubbles that are stacked up upon each other. So these are all potential people in our adult patients' lives who can work in partnership with us to help us safeguard our adult patients. So we don't need to safeguard alone. So why would we when we've got so many other people we can go to? Okay. So early help for adults in Solihull, if your practice has got a social prescriber, all adults 18 and plus. You also have Age UK Solihull for the older adults, and obviously the council as well. If you go onto their website, they often have resources and things that patients can tap into. And then we have the waiting room, which is funded by the CCG, the ICS. If you're not aware of it, it is an app. You can load it on your phones, and you can encourage patients. You can give them the website, and you can encourage them to download it on their phones if they've got smartphones. And basically, it's a whole list of services in Birmingham and Solihull. So, for example, if we click on mental health, it brings up all the NHS services, but all the non-NHS services as well. A lot of them we don't know about. They can be government funded, council funded, charities, lottery funded, and the patients can phone them themselves. They can be proactive. We can refer them, or they can just phone directly. Most of them do not cost the patient anything. One or two may have a cost attached, but it should be clear on the website if the patient has to pay. Then same for Birmingham, some practices have social prescribers. We've got the waiting room. We've also got a few extra things. We've got the route to wellbeing. I'll tell you about that in a second. We've also got a special website to support asylum seekers and migrants. And we also have Birmingham Connect to support. So the route to wellbeing is another resource. The advantage of it, there's an overlap with the waiting room, but the advantage of it is you can put your postcode in and it will bring up all the services that are local to where you live. And again, loads of tabs. Look at all these categories, more categories, day centres, managing your money, and even youth activities, etc. So you know, you can start using that for your patients, and you can encourage them to use it as well. And then we've got the Birmingham Connect to support, full of services as well, and patients can self-refer themselves to physio, to OT through this website. And also in Birmingham, we have 10 neighbourhood network schemes. The city is divided into 10 sections, and they all have neighbourhood network schemes, especially for our adults aged 50 and over, and also the under 50s, but only if they've got long-term disabilities. And these are the 10 areas, and I would really recommend, again, this is part of the documents, I would really recommend you get in contact with your neighbourhood network scheme, because they can really help support you with your older patients who are lonely, or, you know, that kind of thing. And here's just quickly some examples. So in B8, they've got the B men together, chai and chat and chair yoga, lots of services across the city there, food banks, financial help, gardening in Acox Green, some sort of project in Blakesley Hall, dancing in Garrett's Green, and Tai Chi in Wesley Vale. And these are just some of the kind of early help that our patients can get involved in. Oh, and this is similar to like a Citizens Advice Bureau in Yardley. Okay, so just to recap then, to make a good and appropriate referral, you needed to understand the 5 components of adult safeguarding. So we went through them. I hope you know now who to refer, adults with care and support needs, risk enablement, those set of scales. We balance risk against patients being allowed to make their own decisions if they have mental capacity. So we need to know how to assess mental capacity. We now know hopefully what the referral procedure is, and we can understand and make use of early help. So let's quickly test our knowledge. I'm sorry, I know we're nearly up to the 30 minutes, but if you can stay, please do so. And I would like you to put in the chat or lift yourselves off mute. So case 1, we've got 3 cases. An 83-year-old man with dementia is accusing his carer of stealing money from him. Does he need a referral to adult social services? If yes, tell me why. If no, tell me why. Anybody like to lift themselves off mute to answer that one? I might pick on somebody. I know a couple of people of you. Anybody? Or you want me to just give you the answer? This is the easiest one, guys. All right, I'll give you the answer. Yes, he's got care and support needs. He's got a carer, and you know we're thinking, is this financial abuse? So it is a straightforward referral to social services. We will still check his capacity for, we'll still discuss it with him if he understands. But even if he doesn't understand, we would go ahead and make the referral because he is a vulnerable adult. Okay, anybody disagree with me there? If you do, let me know. Case 2, an 18-year-old girl is living at home. Her younger siblings, aged 3 and 7, have been referred to Children's Social Services for neglect. Does she need a referral to adult social services? Have a think, yes or no, and why would you say? Anybody want to? It is supposed to be interactive, guys. If you want to count this towards your participatory learning under the intercollegiate documents, you're supposed to be interacting.
Yasmin?
Yes,
If
yes.
she's 18, do you have to have her consent?
Yes, exactly. So tell me more. So what would you do?
Well, you'd speak to her basically, and you just ask her about what's going on, and you'd then decide whether or not she needed a referral, and then you'd ask her for her consent.
Okay, yeah, you just missed out one thing though, because you wouldn't necessarily refer her. What does she need to have?
Oh yes, so she doesn't really have any care needs.
Oh, as far as we know, yeah.
As far as we know, yeah.
Yeah, exactly. Thank you so much, Mary. Yeah. So basically, we, as you say, call her in, speak to her. Does she have any care or support needs or any other vulnerabilities? The chances are this neglect has not just started. She's been living with it while she was a child as well. She may have turned to drugs or alcohol as a coping mechanism. So that may be enough of a vulnerability that we could refer her. Is she suffering from neglect, or is she able to look after herself? And it might be that, she's got different needs in the sense that she'd rather just get out of that house, and she might want housing, in which case, obviously, that would follow a different referral pathway. Okay, thanks, Maureen, for that. And the last one then, case 3, a 52-year-old man is suffering from depression since his wife passed away. He lives independently, but he's become isolated and his family are concerned. And as GPs, we get loads of calls from concerned family members. So his grown-up daughter's phoned in and said, I'm really worried about my dad, doctor. Can you do something about it? So does he need a referral to adult social services? Yes or no, and why? Somebody different. Don't let poor Maureen have to do all the work. Anybody want to guess? It doesn't matter if you're wrong. It's all about discussion. It's all about learning. No takers. Okay, in the interest of time then. So he doesn't have any care or support needs. He's living independently, yeah? So technically there is no referral to be made here. It does actually, however, come under early help. So again, we'd call him in, we'd speak to him, and if he agreed, we could refer him to the social prescriber. And if he's still, having problems getting over his wife passing away, depending on how, soon or late it is, maybe it's years later, if he agrees, we can still refer to bereavement services like Cruise in Birmingham or the Solihull bereavement counselling service. So that came under early help. Okay, But there's nothing, by the way, if the family is still concerned and say, no, doctor, I think he should be referred to social services, you can say, well, go ahead. There's nothing to stop the family from making their own referral to social services. And in fact, you could say, listen, you know more about him and his situation than I do. And, you know, why don't you fill the form and make the referral? And then social services can deal directly with the family. Okay, thank you for listening. I would love some feedback if you've got time. Otherwise, I know if you've got to rush off, but if you've got time to stay and there are any other cases you want to discuss related to adult safeguarding or related to anything to do with safeguarding, I'm very happy to stay behind. Just come out of this. What I'll do is I'll stop the recording.